Good afternoon, everyone, and welcome to the Health and Adult Social Care Scrutiny Panel on Thursday, 7th of October 2021. I'm Councillor Benzema and I'm the chair of the panel. I'll ask the members of the panel to introduce themselves. Councillor Bill Palmer.
Yes, Councillor Bill Palmer, Kirk Burton Ward.
Councillor Vivian Lees, Hamilton.
Vivian Lees Hamilton, Murfield Gordon panel member.
Councillor Leslie Warner.
Hi, Councillor for Combe Valley Ward.
Councillor Fazila Luna.
Councillor Fazila Luna, panel member.
Dave Rigby.
Dave Rigby, I'm a co-optee on the panel.
Lynn Keedy.
Good afternoon, everyone. I'm Lynn Keedy and I'm also a co-optee on the panel.
Okay, and Councillor Bush will be joining us. Thank you. If we move on to the agenda, item number 1, which is minutes of the previous meeting. Can we have a panel member to move them?
Happy to move them.
Okay, thank you. This meeting is being webcast live and members of the public can watch now live, or it will be on YouTube after for members of the public to be able to see after the meeting. Item number 2 is interest. Any panel members who may wish to declare an interest may do so now. Lynn?
Thank you, Chair. Lynn Keedy and I'm a volunteer with Health Watch, Kirklees and Calderdale. Thank you.
Thank you. Councillor Leslie Warren? You have your hand up.
Hi, yes. I'm a governor for the hospital.
Thank you. Okay, we have no further interests from the panel members. Item number 3 is admissions of the public. We have no admissions of the public to the meeting today. Item number 4 is deputations and petitions. We have none for this meeting today. Item 5 is public question time. We have none. Richard?
Yeah, none received.
Okay. That takes us on to item number 6, which is Health Watch Kirklees. And we have Helen Hunter, who will provide us an update on the work plan and present the Health Watch Kirklees and Calderdale Annual Report 2021. Over to you, Helen.
Thank you very much. Just give me a moment and I'll share my screen with you because I have a presentation to run through, and I will put that onto slideshow. So is that filling the whole screen now? I'm going to assume if that
it's fine, Helen. It's fine.
Thank you. Okay, so good afternoon, everybody. I'm Helen Hunter. I'm the Chief Executive at Health Watch Kirklees and Health Watch Calderdale. And the Scrutiny panel have kindly asked me to come along and talk a little bit about the work of Health Watch in 2021 and the work that we have planned for the year that we are in now, 21-22. So I'm going to try through my presentation to talk to you a little bit about how our work changed as a result of COVID, what we worked on last year and what we're working on this year, and how it ties into the work of Scrutiny. And then at the end, I've put our contact details on just so that they're available, and I can send these slides out after I've done the presentation. I'm really happy to take any questions, but I'm going to try and get through the presentation first so that then you've got the wealth of information, and then anything that you might want to ask, that's no problem. I will try my very best to answer. So I'm going to start a little bit by talking about the impact of COVID-19 on the work of Health Watch. So last year in March, we all went home from the offices, and none of the Health Watch staff have been routinely going back to the office since that time. So it's been a really big operational change for us as an organisation. But what I would say is that the pandemic has spurred us on to develop and to work in new and exciting and interesting ways so that we can make sure that we're capturing the views of the public and making sure that those are being heard. It's all been very different for us, and obviously we have to be mindful of the fact that if we can't be present in our communities, that presents quite a lot of barriers for people who might not have any digital access. So we've had to try and be really inventive and diverse in the way that we've done things to make sure that we're capturing the views of those who might be seldom heard. And I'll talk a little bit about a couple of examples of those as I go along. We've really focused particularly on sharing live insight and intelligence, because during the pandemic, it seemed more important than ever to make sure that people's insight is timely, because things have changed so quickly. So actually it's very quickly information and people's views become out of date. We've done a lot of work to try to refine how we're sharing insight and making sure that information about services lands with the right people at the right time. We saw that we had a really clear role in terms of communicating messages to the public. Obviously, we have quite a diverse range of people that we make contact with through our social media, through kind of our information signposting service. So actually, we felt like we had a really strong role in terms of providing up-to-date, clear information about the pandemic, about vaccinations, about access to services, and I think we've really maximised our scope to do that. We've supported health and care providers to understand how COVID-19 is impacting members of the general public, so that services can be adapted in a timely way. So what I would describe us as is still listening to the public in every possible way that we can and trying to capture those insights, but perhaps even more than ever involved in the work of the health and care system as it's been grappling with such a massive set of challenges, and trying to be as helpful and supportive of the system as possible in terms of understanding. So that's a little about how it's impacted us. Now, some of you will remember that when I've come before, I've split down the work that Health Watch does into 4 different categories. That's around helping individuals, supporting the system to understand the public's views, challenging the system where we think there's something wrong, and trying to work in new and diverse ways. So I'm going to run through those and give an example for each one from our work in 2020, 2021. So starting with helping individuals, we provide an information and signposting service through which we assist people to find out information about health and care provision, and offer them support and information about making complaints, about availability of services. But one of the things that we did during the pandemic is we delivered a telephone befriending service for vulnerable people and people who were shielding. Now, obviously, there was a range of befriending support available to people through the pandemic, and we didn't want to be offering anything that sort of duplicated what would be offered through other fantastic and well-equipped voluntary sector services. So we worked particularly with people who might be additionally vulnerable, so people who had been signposted to us through mental health services, people who might have substance misuse issues, people with learning disabilities, and a member of staff or volunteer made contact with that person on a weekly basis in general for several months to kind of make sure that they were being offered emotional support and sort of friendly contact. And we had some incredible feedback about that service and about the value that had offered to a number of the people who use the service. Sadly, a small number of the people who use that service have actually passed away since we were offering that support, and that's been very challenging for the staff team. But it makes it feel even more pertinent than ever to have been able to offer that support to people and that ongoing link, because it means that during those perhaps final months of their life, they had that emotional support and connection with somebody who invested time. We were also really able, because of our position as an organisation, to support people if they needed to access a service during that time. So We worked with some people who needed support from social care, and we were able to connect them in with services, and that worked really, really well. So it was a really valuable piece of work that we did. If I move on to helping the health and care system understand what people think, typically in the past this has been when services are about to be recommissioned, or if there's a clear problem about health and care services that the system wants to know how to overcome, or what the public think of it. In last year, we actually did some proactive work around COVID-19. So across the summer, so from May up into September last year, we did a big piece of public engagement where we asked people what their experience have been of trying to access health and care in the pandemic. So we had a survey, we had some storytelling tools, and we had information that had come through our signposting information service, which is busier than it has ever been. So we captured insight through a variety of different ways. And as I say, the storytelling tools were a really interesting thing where we asked people to be creative, to send us images, to write poetry, to write down their story, and we captured people's insights in really different ways that brought experience to life. And we got just short of 700 responses to the survey, and then 36 from staff, and about 36 stories, which felt like a really strong, really positive return. Now on this slide here, I've listed the 5 key themes that came out of that work. You'll see there's nothing that might seem particularly revolutionary around access to services, digital access, communication, quality of care, cleanliness, hygiene and infection control. But what I think is really interesting about those themes is that they still resonate with what's happening in our health and care systems now, but the feedback is very different. So if you look at access to services and the feedback that we got last summer, a lot of that was about kind of teething problems that people might have experienced if they didn't have an online account for a particular service and then they needed to have one, or if they had struggled to find out when an appointment was going to take place because those processes just hadn't been established. Actually, now access to services is still an enormous issue and a massive theme of the work that we do, that we're dealing with, particularly around delays to planned care. But it's a totally different set of feedback. And it's interesting to see how it's changing, and that's why it's so important to be providing live information. And we split the information down by different protected characteristics as well, to look at what parts of our communities might have been more impacted by some changes than others. And we've had responses to the report from a range of different organisations. We analysed the data through a specialist tool, which meant that it was really robust, and we've had really strong responses indicating how different key providers in Kirklees are adapting their health and care provision in line with what the public have told them. So in terms of challenging the health and social care system, I hope one day to not be challenging on dentistry, but it seems like that is far off at the moment. Healthwatch in Kirklees has been fighting the corner around access to dentistry, NHS dentistry for Kirklees residents since we first started, so 8 years ago, and it continues to be a massive issue for people in Kirklees. It is now also a massive issue across the country, because of the limited access to dental provision, particularly acutely during the first phase of the pandemic. But actually since that time, most dentists have only needed to provide 60% of their core contract values to be able to receive their full allocation of funding, meaning that actually there's an awful lot less dental availability across the population. And what that means is that we have seen a massive increase in the number of people who are contacting us to say, how can I get an NHS dentist? Some of those queries are such quite run-of-the-mill, and people who are looking for routine dental care from a dentist, they want a dental checkup and they're not able to access one. But more concerningly, we've heard quite a lot of feedback from people who have urgent dental needs, but who haven't been able to get those met until there's perhaps an emergency situation, and the people can access emergency care, but they can't get the follow-up that they might need. And that's the thing that's particularly concerning from our perspective, is that level of urgency that some people might be experiencing without being able to access any care. So what have we been trying to do? We've been trying to feed that into our local and regional mechanisms. So there's a Yorkshire and Humber Dental Commissioning Executive, which Healthwatch takes a seat on, and we've been feeding into that, as well as some dental access work at a West Yorkshire and Harrogate level. We've been feeding back to Health Watch England on a national level because they are taking this on as a national issue and trying to influence the development of dental contracts, which is really, really important and obviously something we don't have much impact on locally. But we're trying to provide as much up-to-date information as we can about how to access an NHS dentist. There have been a multitude of times in the last, well, I was going to say in the last 12 months, but longer than that, where there have not been any dentists in West Yorkshire who are taking on NHS patients, and that is incredibly challenging because dental health is a really significant part of people's wellness, and so we continue to kind of champion that, but we try to provide people with factual up-to-date information about what is actually on offer. So there's a link on our website which we can signpost people to, which provides information about urgent dental care as well as routine access to dental care. But this is a really critical issue as far as we are concerned. In terms of looking for opportunities to do things differently, I've got a few different things listed here. At the start of the pandemic, we ran a COVID Heroes campaign where we asked people to nominate people in their communities who've been really helpful to them in the early stage of the pandemic. And we offered a COVID Heroes award to somebody who'd been running online exercise classes and a local pharmacist, both who've got lots and lots of nominations from members of the public, which felt like a really nice and really positive thing to do. We realised very quickly that we wouldn't be using some of the IT equipment that we use for outreach sessions at the start of the pandemic. So we lent our iPads out to care homes so that they could be used to connect with family members and relatives, when people weren't able to visit. And we worked particularly closely with a facility for people with learning disabilities where that was really, really positively received. As much as we can, we've been involved with local response plans. So we've got involved with a number of the different planning meetings that are taking place locally and are offering insight from our communities into those planning arrangements. So we've been sharing lots of opportunities to engage because lots of things have emerged during this period of time. And as much as possible, we've been working in partnership. We've had a really interesting development to our work working with the Royal Voluntary Service and the Home Library Service, where for people who are socially isolated and perhaps housebound, we've been providing information packs. So people have been receiving some information directly about Health Watch into their homes, and sort of an indication of the different surveys that we're doing, encouraging people to contact us. Actually, these are probably people who would never have had any awareness of Health Watch, and it's been a really interesting piece of work. So in terms of what we've got on our agenda, for now, we are already doing work around delays to planned and routine care and work on access to medication, as well as a multitude of the other things that are listed on this particular slide here and that you can see in our work plan. I'm really happy to take any questions on any of the work we've got going at the moment, but I just wanted to give a bit of an indication of the breadth of the different types of work that we are doing. But how does this tie in with the work of Scrutiny? So obviously we have some shared priorities. I know that it's important to you to be looking at work around delays to planned care, and we will have a lot of insight written up into a report within the next couple of months. We know that you make requests to us sometimes. Sorry, someone's just knocked at my door. Requests sometimes for insight from us so that you can understand something about issues. Apologies, my dog is now barking like crazy. So, for example, we want to ask you to take a look at some of the stuff around dental access. And we know that we get requests from you with regard to feedback about certain services. So you've asked us for feedback about hospitals, and we provided that for the last meeting. We know we're openly invited to attend scrutiny panels, and we want to encourage you to contact us so that you can share issues that are experienced by your constituents and encourage people to get in touch with us to make a change. So I'm going to try and ignore my dog. So one moment. So we've got our contact details on that slide there, and some information about how you can have a review on our website, and I will leave it to any questions.
Thank you for that very informative presentation, Helen. I'll move on to the panel for questions, but before I do, I'm really sorry, Peter, that I did not introduce.
I'm really sorry I missed that.
Sorry.
Hey, Van, I think you were on mute when you were talking about Peter.
All right, sorry, I don't know how that happened. Yeah.
It was a good idea, Chair.
Yeah, I'm sorry, Peter, that I didn't introduce you. Peter is an invited expert witness that has been a panel member for a number of years. Apologies, Peter. If we can,
thank you.
if we can move on to questions for Helen. Councillor Leslie Warner, you've put your hand up.
Yeah, hi Helen. Thank you for that report. It was very impressive. You know, clearly you're involved in many things. I just had one question, which was at the end of your report, where you were talking about access to health services, asylum seekers and refugees, and you mentioned the work that's being done in Calderdale. I'm aware through Sanctuary Kirklees that we're in the midst of having 2, if not 3 more movements of people up here, and whether you had the capacity to be involved with those new arrivals as well.
It's just a shame that Stacey isn't here actually, because she's been more directly involved with some of the work that Public Health have been doing in Kirklees related to the need, sort of like the various health needs of asylum seekers and refugees. And we've had some contact recently with the White House Centre, because obviously that is often where people coming into Kirklees initially register as a patient. So we're really aware that there is going to be some additional people who are coming into Kirklees, and we want to make sure that we are connected, but we don't have a specific piece of work planned around that at the moment, but it's definitely something that we are aware of, and we think that we would probably need to be connected into.
Because could I just add that I know that just in Colne Valley alone, there's a group which is called Inclusive Colne Valley, came out of Black Lives Matter, but there's many people who would be happy, I think, if you were short of volunteers to work with groups or you heard of things, then I think, you know, there'd be quite a lot of people who would be happy to be, you know, offer advice or support. Thank you.
Thank you, that's really useful.
Thank you. Dave, can I get you to ask your question?
Hi, thanks for your presentation, Helen. I particularly like the doing things differently section. I thought that was really interesting. I've got 3 questions. The first one's on the adult social care section, and you refer there to social care co-production with Kirklees. I just wondered if you could say a little bit about what that involves.
And again, I would be well served by having Stacey here with me so she could give you a bit more information. So with regard to the adult social care stuff, we're really aware that there is a significant programme of work that's happening internally with that the council are leading around sort of connecting in with people who might be users of adult social care services. And it's very much about, rather than replicating work that's been done, they're supporting some of the work that is being delivered internally and perhaps providing access to some people who might not have heard about the local authorities' work. So I can ask for more information to be provided about that. It's not something I'm massively close to. Okay,
thank you. The second question's just the next one down on your adult social care list, and that refers to Enter and View. And it says it's on hold. Are there plans to put that back into action, the Enter and View programme?
There are fledgling plans to put that back into process, because obviously there are still a lot of restrictions around going into care settings and health settings, and we wouldn't want to put any of our staff or volunteers at any unnecessary risk. But we're mindful that there is definitely a need, and we have been acutely aware of that during the pandemic, whilst there have been fewer. So if there are concerns about care provision, particularly in residential care settings, family members are often the people who flag things like that up. And that as people haven't been able to go in as they would do, that's something that has that has been of concern to us. So we've certainly been kind of responding to that. We're really aware that across the country, other Health Watch have developed sort of a mechanism for doing a digital sort of enter and view visit, and we're really interested to look at how we might be able to do that. But increasingly, we will be looking at how we can build that back in. So if we have a certain volume of feedback about a particular service, that we can go back in and do enter and view. And obviously we still have volunteers who work with us who are particularly interested in doing enter and view visits, so we're keen to kind of keep that going, but it's not something we've done for the last 18 months.
Yeah, that's good to hear that it will be gradually reintroduced. It's a valuable service, I think. And my final question is on the Connect Eating Disorder service, and it refers to some challenges in that area. Again, could you just say a little bit about that?
Yes, of course. So the Connect Eating Disorder service, as I understand it, is something that it's not that long since it came into being in West Yorkshire, and I think it was some of the initial issues around that we heard. Obviously, very small numbers of people contacting us about, because it's not a service that is used by a significant portion of the population, and we're around kind of access for people in Calderdale and Kirklees. I wouldn't say that's something that we've heard a great deal about in recent months. I think that was probably mostly related to the sort of when that service first started. So it's perhaps something that we need to revisit as to whether or not it needs to continue to be on our work plan, if actually some of those issues have reduced as a result of it being a more embedded service now.
Is it, you mentioned in the report that you've been contacting other Health Watch colleagues in West Yorkshire. Is it something that might be pursued at a West Yorkshire level, perhaps, rather than at a district level?
Yes, and we're often trying to work out what it is that can be best done at a West Yorkshire level, because specialist services like this often aren't available in some of the smaller areas in our footprint, aren't delivered in those areas, so it's a referral to a service that is out of areas. So so sometimes it's best for us to be working collectively on an issue like that, and I think this is certainly one where we would want to work in that way. And as I understand it, when we raised it with some of our West Yorkshire colleagues, they hadn't heard the same feedback that we had heard about the service, which I think is perhaps why we've paused it to see whether or not there's much more feedback about it.
Okay. Thank you.
Thank you. Peter?
Thank you, Habiban. I think, Helen, my questions really, and again, there are three. I think that and answers in 300 words will do. I'm not, I don't want to, because these are more about your impressions than about the report. I think we all find the report highly commendable, and we all appreciate the work that you do on behalf of the people. And the patient's voice. My first one is really about your impressions, and this is not obviously reached a report level. Your impressions about access to a proper clinical examination by a GP. We've all read in the professional press, the BMJ, the Health Foundation, the King's Fund. Lots of reputable organisations have told us that over the course of the pandemic, face-to-face consultations have gone down immensely, to the point of in the worst case of being like something like 70-30, 70 remote. And we all know the benefits of telemedicine. We all know the benefits of a telephone call. We all know it was important not to see people during the pandemic for cross-infection reasons. But do we really have to join the golf club to have a face-to-face meeting with a GP?
Because I think it's a really, really interesting question about, from my view, it's about the different way in which clinical need is perceived by clinical professionals and by members of the public. So I think that when we've spoken with GPs, they feel that a telephone consultation and a face-to-face consultation for some health conditions are essentially exactly the same, and therefore there is no need for a person to come in face-to-face. And I understand in a kind of clinical diagnostic way that perhaps they can say, no, you don't need to come in and see me. I also know that there are members of the public who who feel much more supported if they are able to see somebody face to face, and they feel like they are more comfortable in that situation. And especially when people have been waiting a really extended period of time to perhaps have appointments related to long-term conditions or worsening health symptoms that they might have experienced, and they perhaps haven't been able to access some of the specialist provision that they would normally have, that actually it doesn't feel like it's enough to speak to somebody over the phone. It doesn't feel like that responds to the needs of that person. And I think that there's been some helpful stuff that's come out in sort of national press and policy. I think there's been some stuff that's come out that's been very scathing about a group of people who are exhausted and have been working very, very hard during the pandemic. And it's a really, really difficult balance to tread. That said, there should be an element of people being able to choose how they can access services. So if you feel like you need to see a GP for reason, for a variety of reasons, maybe that's to do with your communication needs, then there needs to be more availability in that way, and perhaps I would suggest a less rigid view of, is it clinically required for you to be seen rather than spoken to over the phone.
Thank you, Helen. And then your impressions on a second one, please. That's integrated care. And really, are things any different now? I mean, the pandemic was terribly disruptive, we know that integrated care is in its infancy, but we've just seen before the meeting the coordination is getting better. Is there anything that sort of hits you in the face that says people coming out of hospital are not being looked after, or people are being sent into hospital unnecessarily? Anything along those lines?
I think that in terms of integrated care, the pandemic was great at whipping away some of the barriers that we might put up between services. It made people think, can I do this, rather than is this part of my job description, if that makes sense. And it facilitated people to work outside of the boundaries of perhaps some of their work. One of my worries at the moment is that with the amount of pressure that there is on the system and the amount of demand, that people are defaulting back to, is that my job? If it's not my job, then I could do with it being somebody else's responsibility because I've got so much on. So I feel like there's some of that happening. I don't think there's anything specific that I would say that we're hearing a lot of feedback about that relates to the integration of the system. But one of the biggest things that we are talked to about on a regular basis is this system. I need this type of care and this type of care and this type of care, and none of them talk to each other. So it's all separate and it's all still coordinated by me. And I would say we still receive that feedback with the same frequency that we did before the pandemic.
Thank you. So it's still a little bit cosmetic, but thank you. And then the last one, please. You do talk about this in the report, and that's about maternity services, and in particular the concern nationally. The Ockenden report is imminent, and we know on Shrewsbury and Telford. Are we sure that we've got nothing like that happening in Kirklees?
I might not be the best person to answer that question. I would say we haven't received any feedback that indicates something that we would need to be really, really nervous about. And if we had, then we would be flagging that left, right and centre, because that is our role. So I don't think that we have a particular service or a particular area where it feels like there is a significant discrepancy between how people experience it in Kirklees versus how people might experience it in Leeds or in Wakefield. So I don't think, but I would never say for certain because I can't claim to know everything, but that's not how the feedback that we are receiving feels.
Okay, patients are a good barometer, so that's yes. Fine. Thank you, Helen. Thank you, Chair.
Thank you. Councillor Liz Smage.
Thank you. I just wanted to quickly say about dentistry. Absolutely agree, very important area of work, and there's going to be even more a backlog, I would have said, after the past 18 months than there ever was. I just wanted to let the committee know that I have actually raised it for a possible agenda item at West Yorkshire level as well, because the ICS, I believe, will have some involvement in dentistry commissioning going forward. So I think it's important that it is raised on as many levels as possible, Helen. And thank you for your point today on dentistry. Thank you.
Just a follow-on comment from what Councillor Smage has just said about dentistry. In the past, there was that if you've not an NHS dentist, if you've not visited the dentist for 12 months, they were striking you off. Are they still doing that, or is there some sort of leeway with that following the pandemic?
So that isn't part of dentistry contracting. That is decided by the individual practices with regard to their rules around what means that you can or can't stay on their list, because nobody's technically registered with a dentist. Your details are just held on their patient list. So we haven't seen the same sort of instance of that happening. I think probably because it would likely result in an awful lot of sort of negativity for local dentists if they were to do that. They do still strike people off if you have an appointment and you don't turn up. We do still hear examples of that. But in terms of you've not been for this length of time, that's not happening because people haven't been able to go for a certain length of time. But that's very much decided by the practice and isn't decided at a sort of central level.
Okay, thank you for that. Any further questions for Helen? No. If there's no further questions, I would recommend the panel receive the information that Helen has shared with us this afternoon. And thank you, Helen, for attending the meeting this afternoon and providing the panel an insight into the wonderful work that Health Watch do. Thank you.
I apologise for attending with my dog. I apologise.
No worries. That's the joys of working from home. Okay, and if we can move on to the next agenda item, which is number 7, winter pressures. Richard Parry, are you going to be kicking us off on that item?
I'll just do that briefly, then I'll hand over to John to run through the slides. So we welcome the opportunity to bring the winter plan. It's something we've done over the last few years. I'd reflect that probably the first year we did this, we brought a series of separate organisational plans. I hope that this current version shows that we're operating much more as a system and taking a whole system approach to providing health and care services through the winter period, recognising, of course, that in terms of more recently, winter's referring to it as a winter plan is probably feels slightly odd, given that actually we need to plan for variable levels of demand across the whole year. But I very much hope that this is seen as a system approach and demonstrates where we've got to in terms of our partnership working across the system. What we'll do in a minute is just let John drive the slides, and some colleagues will come in as well. Then obviously we'll be able to happy to take questions at the end of that. So I'll perhaps just hand over to John to drive the slides.
Thanks, Richard. Thanks, Councillor. So for those of you that don't know me, my name's John Palnaby. I work for Kirklees CCG, and I work on the Urgent Emergency Care Programme Transformation. So I have some kind of oversight and input into various winter plans and various plannings for different partners. So I'm about to share my screen. So I leapt up just then and left the screen because I was learning from Helen, and I've just thrown my dog out. So my dog is in the garden. So hopefully I won't have Helen's problem. So let me just share my screen. Okay, so hopefully you should all be able to see the screen now. So just before I start going through the slide set with you all, as Richard said, this is very different to previous years in that we are now approaching this obviously as a system. We have a system plan in place. For those of you that have been around for some years, on occasions such as this, as Richard mentioned, it used to be a case of all partners coming on board to the overview and scrutiny committee, all presenting their winter plan, and then that was combined in some kind of oversight slides. it was quite inconsistent way of working. It was very much of a silo way of working. So what we are now doing is that we're now looking at the whole system, what systems are in place, what risks are in place, where risks are owned, and also where risks are shared, and what common risks there are as well. So we've taken a lot of learning from COVID, and it also reflects our move now. It's like a transitional period, if you like, for a move into this integrated care system way of working that we're starting from April of next year, although we are doing a lot of work on that now. And also to let you know that this kind of way of working is also going to be feeding into the integrated care system West Yorkshire view, because it will feed into our colleagues in the ICS to be shared with other ICSs across the region as well. So although I don't go into a lot of detail within this specific presentation regarding partners' owned winter planning, I've just picked out some highlights and common risks, etc. It's just for members to be assured that there are winter plans that have been developed by all partners that sits behind all of this. This is just kind of summarising what we need to do. And although, again, this winter plan is for our Kirklees system, there are also complementary winter plans that are being presented across both the Mid-Yorks footprint and the CHFT footprint, which complement, not duplicate, what we are trying to do here. So Richard's mentioned that we have got partners on the meeting as well. So at one point I may call in the partners just to contribute to some of the things that they may be doing that I haven't captured on the slides, but they'll also be present at the end of the meeting in order to answer any questions that you may have. So this first slide just talks about how the approach is as far as the winter planning. So it says that obviously we've had to do it as in a recovery phase, and also there's very challenging circumstances. Not only have we got to present a winter plan, but there's also doing winter planning whilst in winter pressures in a period whilst all partners are still in a recovery period. So when we're talking about the recovery period, we're looking at obviously our acute trusts and standing back up to full capacity of their elective care programmes. And also there's things such as the mental health backlog, the build-up of demand in community care, as well as with our social care colleagues and the number of reviews that are outstanding in community and the support that's needed in community as well. So that's the kind of context that we've got there. But it's just to let you know that resilience and safety is the key. What we're trying to do is adapt to changing scenarios, and those scenarios, I've put some of those with the arrows on the right hand side. So you've got some of those scenarios affect all partners. So you've got like the weather scenario, the pandemic, the seasonal infections. This impacts all partners, whether they are in sort of like the health or the social care system. So what we're trying to do is look at it to make sure that risk is evenly spread where possible, so that when we're looking at this in responding to risk, that a partner in responding to a specific risk doesn't inadvertently adversely affect another. So we've got a lot of emphasis on that in this plan, and it's part of that which is discussed on the system has what we call our silver calls every Tuesday. And that they do concentrate on, OK, well, a partner may be deciding on to do this because they've got a huge risk or a huge pressure. And we discuss in those meetings things such as, well, OK, if you're going to do that, the ramifications is it may have this impact elsewhere. But I'll be covering that later on in the slides. So it's just to really sort of like list here some of the partners that we're working with. So all of those, I imagine that you are going to recognise, so all working together in a way that, as it says there, benefits the residents across Kirklees. It's also a reflection again of this transitional period where we're moving into this integrated care system way of working, and these will be partners that will be reflected on what is going to be known as the integrated care partnership. But the good news is, as far as Kirklees is concerned, is again, as Richard mentioned, over the past 3-4 years, there's been a hell of a lot of partnership working. So we've got established ways of working and established relationships across all of these partners and with those partners as well. So it's nothing new to the Kirklees system. So I think we're in a good position to move into this ICS way of system working. So going on to the expectation, I've mentioned there are other plans as well. So we've got other plans which had to be submitted into the ICS early this week. So on Tuesday, plans had to be submitted across the 2 acute footprints, because this is the way the ICS sometimes recognises some of the systems. So the systems, the acute systems submitted their plans, but it was all coordinated. And just looking at how it was done, it was looking at what are known as the key lines of inquiry, which are on the left-hand side of your screen there. So you're looking at things such as demand, capacity, workforce, exit flow and external. Now, not in, I'd say previous years, not normal years. In previous years, these key lines of inquiries have been dictated by NHS England. However, they haven't been as prescriptive as that this year. So these are key lines of inquiry which has been developed by the ICS and circulated between partners. So we're all very aware of them across all of the partners across the Kirklees system. So that's what the those clues have been factored into planning with all the partners' winter plans that they've done. And then on the right-hand side, there are some of the generic considerations which are in place, and they're generic considerations whether you're working across the acute footprints, place or individual partners as well. So they're just some of the more generic considerations as well. If I can just focus on what we've got down there for our preparedness for winter. Each system had to score themselves as to how we are prepared for the winter. Now, I mentioned that we had to do our submittals across our acute footprints earlier this week. This slide set was done prior to that submission being done, so that was able to be circulated amongst councillors and members. So on there we did have an initial grading as P, saying that, yeah, we have fully understood plans and we've got all mitigations in place. Since we've worked with our systems across our acute footprints, both acute footprints have put in an amber green submission. So we're saying that there are places that we are fully ready for, but there are some places that we're not. So to give you an idea of the rationale, like we've got clear plans, we've well cited on the challenges, we've got robust working arrangements. However, there are some outstanding actions. So we need solutions to reducing TOC, or the transfer of care list, from both of the acute trusts. We need to mitigate some of the risks that are well known within the social care market. There's further what we know as risk stratification or sharing to be done. And we need to have a system approach to predictive modelling. So this slide is not up to date. The submission that went in for the Kirklees system is amber green, based on what I've just mentioned with that rationale and those outstanding needs. So that is what's been submitted into the ICS, and that's what we are confident of in the Kirklees system, in that we think we are prepared. We've got a lot of plans in place, but we are well aware that there are some items that we still need to continue to work on. So the position for Kirklees is amber green. So looking at the Kirklees response, what I've just tried to do on this slide is just pull out some of the highlights from different partners as to what they are doing for winter. So for winter here, as far as on the CHFT footprint, so across Calderdale and Great Huddersfield, we've mentioned the 10 innovation schemes, and I didn't list all 10, but I think Bev's on the call at the moment. Do you want to mention a couple of them, Bev?
Yeah, hi, my name's Bev Walker. I'm the Acting Chief Operating Officer at CHFT. So yeah, we set up an urgent care board a couple of years ago where it runs with our clinical directors, so our medical staff and nursing staff and allied health professionals, and they're really heavily involved with our winter planning. We obviously do have some winter funding that comes year in year, and I've worked in the organisation a long time, and it does come every year. And so what we've done is we work with them to develop specific innovation schemes that we can either put in non-recurrently or recurrently, because often we describe a winter plan, but we know, to be quite honest, we see pressures throughout the year, and often we need to put things in that are recurrent, not just non-recurrent for winter. So one of our particular schemes that was developed this year was specifically looking at improving quality and safety around discharge planning, more specifically around discharge medication. So what we've looked at introducing, and we're well on with this now, is a pharmacy prescriber working with some more junior medical staff. So they will do the actual medications for patients to go home on. What we find is it's a much timelier service, so that means we can discharge patients earlier on in the day, and especially when they're going into specific care settings, because as we know, it makes it really challenging for our care home sector if we discharge them late into an evening. It also looked at improving education with the patients around the medication, and then linking in with our pharmacists in the community to ensure that there's a follow-on process. So it's not just as they go home, but we follow up a number of days and weeks afterwards. And so that's one of the initiatives. I think the other thing for me that I wanted to mention was obviously, as we know, the out of hours period within the hospital, we reduced a lot of staffing levels, and it's historic. We've done that for a long time, but what we've done for our winter period is we're increasing, certainly in both medical and allied health professions and nursing. Some of that's challenging, there's no doubt, because we know there's significant issues around staffing and recruitment. But we're working through with our clinical teams about how we can improve the rotas, but specifically for the out of hours period. So that's just two of the schemes that I thought I would mention.
Thanks a lot, Bev. And then, as I say, I've pulled out a few of the other things from the CHFT winter plan there regarding ambition for flu uptake and lead nurses in patient flow areas. And I realised, and apologies, that I always go through this to make sure that I haven't used any acronyms, and I've realised I've used an acronym there. So SAFER, that's just an acronym for S is for senior review by midday of patients, A is for all patients have an expected discharge date, F is for flow of patients at the earliest opportunity, E is an early discharge 33% before midday, and then R is review, so all patients have a multidisciplinary team review with a home first priority as the target on that. So apologies for putting acronyms in there, because I'm always conscious the NHS is very heavy on those. So just moving on, I've mentioned some of the ones that I've pulled out from the Mid-Yorkshire plan as well. And in the same way that I've just asked Bev to actually highlight any, I know we've got Joe and Andrew on from Mid-Yorkshire. Did you want to add anything specific that you want to highlight from a Mid-Yorkshire perspective as far as any kind of winter planning? I've just pulled out some of the priorities that I know you've discussed at your A&E delivery board there.
Thanks, John. My name's Jo Halliwell. I'm Deputy Chief Operating Officer at Mid Yorkshire Hospitals. Very similar, I think, in terms of themes to those that Bev's just described from the Calderdale and Huddersfield Acute Trust footprint. So we are really concentrating on working quite hard with our system partners, and particularly local authorities and community-based care, to reduce the number of patients who stay in hospital for longer than they need to for their acute care. And that is a really strong element of our element of quality discharge delivery moving forwards. We similarly have a number of patients who we are seeing staying within the acute trust for longer. That's not to say that they are inappropriate, but some of that is a reflection on some of the longer staying patients that we've seen admitted with COVID and respiratory illnesses. So equally, we're looking at how we are going to meet their needs moving forwards, because, as you know, staying in hospital when you don't need acute care is not necessarily the best or the safest place to be. So we're also concentrating on how we can support the safe discharge and the continuation of care for those patients that are not necessarily needing to remain within the hospital for that. The other thing that we are looking at, which we've referenced on here, is the same day emergency care. So we already have a significant number of patients that access emergency care on what we call an ambulatory basis. So we don't admit them for that care. They attend for their treatment and then subsequently discharged on the same day. And we're working very closely with the national team to expand the number of patient pathways that are suitable for same day emergency care, and making sure that we can maximise that opportunity to help support patients better, so that they don't end up with an acute stay when they really don't need or want one.
Okay, thanks a lot for that, Jo. Thanks a lot for that input. So there's some of the schemes that are across both of our acute footprints, which obviously affect either North or South Kirklees. But then there's some partners that obviously work across the whole of Kirklees. So we've got some of the highlights that I've highlighted there as far as some of the schemes that are in place from colleagues at Lacala, from Local Care Direct. There's also yards that have got schemes going as well, but I've mentioned there only one there from Kirklees Council, but Kirklees Council, major partner in the health and care network. So I wondered if Amanda needed to expand on anything additional as far as anything that you wanted to promote that Kirklees Council are doing to support winter.
Just as highlighted there, one of our key things is to have real visibility of working in conjunction with Calderdale and Wakefield councils of people who are needing discharge, so that we're working to expected discharge dates and helping to safely discharge those people from the acute trusts in to get the right level of support they need to continue their recovery, preferably in their own home. I think one of the other important things that we're doing at place and in conjunction with Locala colleagues is to work to enhance prevention, so that we're trying to really develop anticipatory care, so that we, as rather than working in silos, we have coordinated approach to people who live in the community with long-term conditions. We can anticipate that some of these conditions will have fluctuations that we need to plan for, and we've got a programme of work to try and go at pace to ensure that we are supporting those people in that coordinated way to avoid unnecessary admissions to hospital, to help them and their carers and families to be more resilient moving forward. So, and I think the other thing as a council is that wider prevention in conjunction with our community plus partners, community champions, to make sure that those people who are isolated and that's so much more compounded whilst we're still in a situation where we're dealing with the coronavirus, that we're reaching out to them and we're being proactive in making sure that they get support and we avoid crisis situations developing wherever possible.
Thanks a lot, Amanda. So like I said, they're just some of the schemes that I've pulled out of the various winter plans that partners have got. We've also got Swift on the call. So Sue and Roland, did you want to mention anything on behalf of mental health and Swift?
I think, John, just to sort of recognise our place within the Kirklees whole system, and as you've mentioned, you know, our involvement in the Silver Calls is really important. And one thing that we've been working really hard at is to make sure that our patient flow works as effectively as possible, because we know that if we're unable to manage that, we can push demand back into the acute trusts. And you've mentioned in the slide set that we're looking at A&E attendances and trying to manage those differently. COVID impacts on mental health services probably slightly differently to other parts of the whole system. And we do continue to see a rise in referrals due to the psychological impact of COVID and perhaps some of the delays that in people accessing services early on in the COVID period. But so it just in summary, it's just to acknowledge that we do understand that we've a part to play in the whole system and managing patient flow and making sure that we have sight of flow 24/7. We've invested some additional resource to manage patient flow out of hours, just to make sure that weekends, for example, don't have a detrimental impact on the whole system.
Okay, thanks a lot for that, Sue. And just before I move on from this slide, that last bullet point there where we've got increased access to extended services in primary care, that is actually not just increased access, that is additional capacity, because I think it's an extra 45 minutes per day of primary care access per 1,000 patient population per practice has been commissioned across Kirklees in order to support increased access into primary care, and that's been replicated definitely, I know, over in the Wakefield patch. I'm not unsure at this stage as to if that's been replicated in Calderdale. So that's just what that last bullet point is. So just moving on, if I can. Yeah, so I've mentioned earlier in the presentation that this whole thing regarding risks is something that we have really focused on as far as a system, wanting to know that if people are going to be managing risks in one part of the system, recognising that may have an impact in another part of the system as well. So looking at some of the broad risks, I've listed some of them there about COVID surge, workforce pressures has been mentioned already, weather events, power outages, and so on. Now, some of those, when it comes to when I talk about mitigations, we don't have to reinvent the wheel. We look at some of the systems that are in place already, such as the emergency planning resilience system, whereby all we need to do is make sure that the health and care system has got a very loud voice in the planning of that emergency planning. But there are other things such as we do have to do ourselves as a health and care system and partners. So just looking at something like that long Christmas break. Christmas this year falls, Christmas Day is on a Saturday, Boxing Day is Sunday, and then obviously you've got 2 bank holidays after that. So it is termed as a long Christmas break. So I know partners are doing a lot of things, recognising that risk and doing mitigations as far as workforce planning for leave, etc. over that specific period. So we've got those broad risks, but then what we've tried to do is, as opposed to identify individual partner risks, this is more so risks that are recognised in different settings. Now, we used to talk about this as far as like pre-community, sorry, pre-hospital, hospital, and then hospital discharge. We've tried to change this because obviously hospitals are a major partner across the whole of the Kirklees system, but it's trying to recognise that all partners do carry risks. So now you've got what we're trying to do now is have it as community risk, hospital risk, and then discharge risks. And those discharge services are not just discharges from the hospital, but it could be discharges from other services into the community or into another service. So that's why we've got this different wording, and this wording reflects what we've taken to the Urgent Emergency Care Board, certainly across the south of Kirklees and the Great Huddersfield and Calderdale Urgent Emergency Care Board as well. So you've got some of the risks there. I won't go into a lot of detail on them. It's just a case of like for members to actually recognise that there are some risks that are in the community. There's different risks when you get into a hospital setting and the services that are available in that hospital setting. And then you've got further risks as far as discharging out of specific settings. So that's just a case of what those risks we have. So going back to those like broader risks, there's some of the mitigations that we have here for those broader risks. So there's things whereby just picking up one of those bullet points, that reviewed command and control arrangements. I'm just reviewing currently the surge and escalation plans to make sure that that is tied in across the whole of the system, so different partners recognise what those surge and escalation triggers are. So we're just reviewing all of that at the moment. We are looking obviously at that first bullet point as far as staff support and wellbeing arrangements, because that is one of the major issues that we do have across all partners. There is so much burnout in the health and care system, there's so many vacancies being carried, so we have to make sure that we've got those staff support and wellbeing arrangements in place. And then that second to last bullet point I've got about the robust emergency preparedness, resilience and response planning. On that element, it's a case of where we don't have to reinvent the wheel. It is just a case of the health and care partners having that voice in that process. So when things happen, we don't have to set up a new emergency system. It's a case of like we can build on the one that's already established across Kirklees. So going on about other mitigations, again, following the same format, that I didn't want to specifically highlight mitigations that individual partners doing, because it's a case of mitigations which are being carried either in the community, in the hospital or in discharge services. So you've got different mitigations there, and just touching on some of them, you've got the urgent community response rollout, which is being rolled out across Kirklees. So this is your 2-hour response. You've got working closely on the community side with partners. So we've re-established all of our mutual aid agreements as far as if mutual aid is required, people know, or partners know how to call upon it and what they actually can call upon. Within the hospital, as far as mitigations, Bev's already touched on as far as the schemes that are going on as far as CHFT about the use of virtual clinics. And that's something that's been taken forward in Mid-Yorks as well. There's comprehensive bed planning in place within both hospital trusts as far as what is actually needed, what the demand is, and what would happen if that demand had exceeded. So there's lots of planning regarding that. And then that last point about increased routes into the acute without accessing the emergency department. So this is SDEC, which is the same day emergency care that Joe mentioned earlier. And this is with SDEC, we don't want people having to get into the ED department, get into A&E in order to get same day emergency care. It's a case of like, how can we refer directly into SDEC, be it from primary care if there is that need there, or indeed if people are being transported by YAS and getting them directed directly into SDEC as opposed to going to the emergency department. So that's again one of the mitigations that we've got in place within the hospitals. And then as far as discharge services, we have mitigations in place, regular daily multidisciplinary meetings to sort out patient flow in both, well, in all hospitals, both across the two CHFT hospitals and the Mid-Yorks footprint ones as well. And then also regarding this kind of system way of working and partner way of working, I've mentioned the commission of designated beds for the use of COVID positive discharge patients, whereas previously it was a case of like when there was a patient that was COVID positive but not symptomatic as such, but they needed to discharge it from their bed because there was no acute need for them to be in there. It used to be rather difficult for Wakefield trying to place them in one area, Kirklees trying to place them into beds, and Calderdale trying to place them into beds as well. There is now 9 designated beds in order to support that CKW system. In order to support discharge out of those, and that's a real way of system and partnership working. So continuing through as far as governance, and this is just a quick idea as to where all of this sits as far as the governance, as to what is actually happening with pressures in our system and winter planning. So it's just to first, let's say that there's robust governance in place with very clear escalation processes which are continually being re-evaluated and reassessed. And they're agreed by all partners at different forums, including the Urgent Emergency Care Board, which, for those of you that are not familiar with that, that's the old A&E delivery board across Calderdale and Huddersfield, and that's the A&E improvement group across Mid-Yorkshire. But we also have things such as the system pressures meeting, system goals, and this Kirklees Opal system score KSOS meeting as well. And also to mention things that tend to work extremely well, which I know learning needs to be spread, further afield into the north part of the system is things like MAID, which is a multi-agency discharge event, which is a call. Well, it's a call that takes twice weekly across the south side of the system, which in effect goes through line by line every patient that is on the transfer of care list. So these are patients that are medically fit for discharge out of the CHFT trust, either estate, and then any blockages are identified, and then partners come forward in order to be able to support the discharge of that patient to the best place for them at that time. They are extremely effective and are able to be stood up and down as the demand may be. Prior to COVID, it used to be normal that we used to be able to step those down to once a week during the summer periods and then step them back up to Tuesday, Fridays during the winter periods. But there has been times when it was a case of we really needed to move some patients that were medically fit out of the hospital beds. So those MAID meetings were stepped up to Monday, Wednesday, Friday, indeed sometimes daily, depending on the pressures within the hospitals. And the similar activity that takes place in the north side on the Mid-Yorks side of things with health and social care tactical meetings. And like I said, all of those meetings there can be stood up or down as the demand may be. So just going on to a summary. So it's just for assurance for everyone on the call here that partners in the system are working together. We have built up really good relationships over the past 3 or 4 years. It's to let you know that all partners have full winter plans, which are collated into this one single plan for Calderdale and Great Huddersfield. And then that plan links with North Kirklees and Wakefield plans. So they're the acute footprint plans that I mentioned earlier. That was submitted on the 5th, on Tuesday this week. So it's just so that you know that there's this whole link between having a Kirklees Place plan, which covers Kirklees Place, but the codependency on the 2 acute footprint plans as well. It does say there that there's some risks that I've included there, but there's a lot more detailed risks and mitigations included in the full plans that have been submitted to me by partners, so I've got oversight on those. Also to say that previous learning and winters are considered in all of the 21-22 planning, specifically with COVID and some of the learning that we've taken from there, but also things such as I've mentioned earlier with my review that I'm doing of the surge and escalation triggers as well, so that all partners are on board with all of that, because they have changed since the onset of COVID. And to give you an example of that, when we have people on the transfer of care list, there used to be triggers on that transfer of care list as to whether we needed to instigate additional silvers or instigate a gold planning meeting. Those triggers, I think, from memory, there used to be about, if you had 70 or 80 Kirklees residents on the CHFT transfer of care list, that used to trigger silver. There is no way that we would actually stand for that now. It's a case of, like, if there are about 25, 30 on there, it's a case of people start getting tetchy on that. So it's a case of ensuring that the surge and escalation plans reflect the new normal that we are working in. And then it's also a case of reviewing risks and mitigations throughout the winter, reacting accordingly. So all of the plans, both the 2 acute footprint plans and this Kirklees plan, isn't just a case of here's the plan and have a look at it, I'll present it, and then we all walk away and pat ourselves on the back and say, haven't we done well? It's a case of it is a moving beast, and we will continue to review this throughout the winter period. And indeed, as colleagues mentioned earlier, it's not just winter now, it's pressures within the health and care system across the whole of the whole year. And then finally, just to let you know that within all of this, there is the voice of the resident patient through our colleagues at Health Watch and etc., and their experience of services continue to inform developments and improvements to the service. So that's how we've approached our Kirklees winter, going into winter as we are at the moment across the health and care system. So if there's any questions of me or partners on the call across the health and care system, by all means do ask. I'll stop presenting now so I can see, Chair, if there's anyone that wants to ask any questions.
Thank you for that very informative presentation. We have a number of people of wanting to ask questions. If I can take Lynn first.
Thank you, Chair. I've just got 2 questions, please. I'll mention them both together and then the responses can be made. Under the broad mitigation section of the presentation, the final bullet point mentions 4x4 access, and I just wondered if we could have an explanation about the meaning of that, please. And then on the final page of the presentation, under summary, again, the final bullet point that talks about the voice of the resident and patient and their experience of services continuing to inform developments and improvement to services. I would like to see the word carer in there too, because I think there is a wealth of expert knowledge to be had from that source. Thank you.
Thank you. Which officer would like to respond to that? John, are you going to do it or is it another?
I was going to say I'm happy to, John.
Yeah, sure, you go.
Yep.
And I've got my hand up as well, Richard, for
Yep.
the actual detailed explanation, so I'll let you go first.
Super. So in terms of the 4x4 deployment, we've got a set of multi-agency arrangements that in the event of adverse weather, we make available, for instance, the 4x4 fleet in the council that can be deployed with drivers to support both kind of the social care sector and colleagues in the healthcare sector, particularly Locala. So we've used that previously, obviously, as you might expect in the event of snow, but also where we've had localised flooding. And that's now built into our standard plans. And then you're absolutely right. It would be helpful if we added in the point about family carers. Just to provide some reassurance, myself and Karen Jackson, who's the Chief Executive of Locala, are the kind of joint SROs for the West Yorkshire-wide carers programme. And at the programme meeting yesterday, we were looking at a report into the experience of hospital discharge from a family carer perspective over the pandemic period. And there's a number of items of learning in that we're going to be working across West Yorkshire to embed. So I hope that just provides some reassurance that whilst, you know, we haven't been explicit in the bullet point about carers, they are very high on the working of the kind of both the West Yorkshire and the place-based arrangements.
Thank you for that.
Do you have a supplementary?
Yeah,
no, thank you. That covers what I wanted to ask. Thank you.
Thank you. John.
Sorry, Chair. I was just going to say I am due to present this kind of presentation in future other forums and governance processes. So I will ensure that that bullet point is amended in that to ensure that carers are included in that bullet point as well.
Thank you. Dave, would you like to ask
Yes.
your question?
Thank you. Yes. A couple of questions on the Kirklees response page. The first one relates to CHFT. There's a mention there of the 100% ambition for flu vaccine update. I just wondered, first of all, what's the previous percentage achieved in terms of vaccinating staff for flu, against flu? And secondly, is there a kind of linked ambition in there to further increase the number of staff who are vaccinated against COVID?
Thank you. Which officer would like to reply to Dave?
Dave, are you looking at the hospital specifically, or wanted to look at more wider out, more in the community as well?
Well, specifically about CHFT, but if you've got a wider answer as well, that's great.
Well, not necessarily, Dave. Not necessarily. From a CHFT, I think every year we've always had a target around about 75%. I think, and right. Colleagues can put me right if I'm wrong with that. I think we've always achieved that, and usually better than that. But for as far as we're concerned, that's probably not good enough, especially with the experience we've had throughout the pandemic. We've had very much a good uptake, certainly with our vaccination programme for COVID already, obviously for the first and the second jab. And we've only just started, to be quite honest. I think we opened up the appointments for internally for our staff the last week or the week before. So it's early days for us, but and we're being really flexible. Obviously, we go to the staff as well as putting clinics and things on. So we don't anticipate it being something that's difficult. And we're also offering they get the COVID jab in one arm and they get the flu in the other at the same time. And most colleagues are taking that up at that point. So I'm happy to give you an update later on, Dave, maybe as we get closer, as we get move further on into our programme. But yeah, that's where we are at this moment.
Okay, and has the COVID booster programme started?
Yeah, that's what a couple of weeks ago. So that's what I said. We're having you have your booster in one arm and your normal flu vaccine in the other arm. So.
Okay, and my second question on the same page. It's on the
just on that. Dave, can we ask Joe Halliwell from the Mid Yorkshire to give you a reply on that one before we move on to your second question? Sorry.
Yeah, thank you, Chair. A very, very similar picture. So similar timeline. We reopened our vaccination hub 2 weeks ago to commence booster vaccinations. And again, similarly, we're offering both COVID and flu, which a big proportion of our staff are taking up. So again, very similar to Bev's update from a CHFT perspective, and we're continuing to pursue that. We've obviously got the time element in terms of the gap between your second booster and your second vaccine and your booster. So we are phasing people back in accordingly. So that timetable may also impact on our compliance because you can't have your booster until you're in a window of opportunity to have it, if that makes sense.
Okay, John, are you wanting to reply to Dave? Have you got your hand up for that? Or?
It's just to supplement this idea of the 100% flu uptake. What I was trying to reflect on that slide is that within the CHFT winter plan, their ambition is to have 100% uptake of the flu vaccination. The NHS England standard is 100% offer of a flu vaccine, which is very different to uptake. But like I say, CHFT are going with the actual 100% uptake as opposed to offer, which is very easy to offer somebody a service, and whether they take it up or not is another matter. But like I say, that's what I was trying to reflect on that slide.
Thank you. Dave, your follow-up question.
Yeah, good. Thanks for that clarification. Yeah, it's on the Kirklees Place section, and it relates to Lacala. There's a reference there to a whole system-based redeployment review, and I just wonder what that was.
So, hi Dave, it's part of a piece of work that we're doing particularly with CHFT around something called Perfect Storm. So it's part of the winter planning. And what I agreed to do was to start to look at something that we could do to build on our already existing admission avoidance work. So we've got four programmes that we are working on at the moment. So an example of one is and this is across Calderdale as well, what would be the standardised offer to support CHFT at time of crisis? So traditionally what we'll get is kind of a call for some community staff to go into the acute. So we phased it to say, actually, when it happens again, we will field a number of intermediate care, rapid response skill set staff into the same day emergency care ward to see if there are patients in there that we could transition out that same day with support and care. And then another example is that we're just working with one of the ED consultants to look at how we link the technology that exists in ED in CHFT through into our emergency community response team and our care home support team. The idea being to keep the patients at home where possible, where they don't need to go into hospital. And then we started to replicate that in with Mid Yorks as well, so that we'll do it across Kirklees as a place.
Good, thank you.
Thank you. Councillor Leslie Warner, do you want to ask your question?
Thank you. Yeah, this is just again about vaccinations. The 100% aim. It's more to do with the COVID vaccinations. I just wondered how, as an authority, we were managing with the young, who I happen to know personally still, although we've had increasing numbers coming to the vaccination centre locally, I am aware that there's still a certain mistrust, and I'm wondering if anything extra is being put in to ensure that you get as close to 100% as you can before the worst of winter comes on.
Thank you. Who would like to answer, Leslie?
John, were you going to have a stab?
Yeah, if I can come in, because I as I say, I'm flu lead for Kirklees, and obviously there's a big overlap between what we're trying to do with the COVID programme as well. I will hold my hands up now and say our vaccination uptake of the 16, 17-year-olds is the poorest in West Yorkshire. The specific reasoning for that is our primary care networks and the offer that they were doing as far as doing the uptake on those earlier cohorts. We were behind everyone else in West Yorkshire. They didn't sign up as quickly as possible, so therefore 16, 17-year-olds were unable to access or be invited directly through from their primary care network, i.e. GP, in order to get that vaccination. They were totally reliant on them, the 16, 17-year-olds or their families being proactive and booking them into the vaccination centre at John Smith's. That issue has now been resolved, and we are now seeing a much higher uptake of those 16, 17-year-olds. There's still a lot of work to be done, and we are trying to be innovative about it, such as having vaccination centres at the Huddersfield University campuses, etc. So we are still trying to do all of that. I don't know if Jane, because we rely very, very heavily on Locala as a partner to deliver a lot of our COVID vaccination programme. Jane, do you want to add anything to that?
Yeah, I was just probably going to add, Councillor Warner, for a little assurance. We've started the programme of vaccinations in the 12 to 15-year-old age range, and we've had some really good support and uptake in a number of the schools across Kirklees, and I'm conscious that I'm due to come back to OSC next month anyway with a couple of other things that I need to talk about. I'm happy to kind of write in the report the COVID element and what we're doing, if that would be helpful in terms of specifically the younger age range.
Thank you. Do you have a supplementary?
The only thing yes, please. Sorry, it's actually some of the older ones, the sort of 22 to 30, that I'm noticing. And given that Wales have just, as you know, by a whisper, have passed a rule saying, 2 vaccinations before you can come into nightlife, etc. Now we're not there yet, and we may never go there, but I do know quite a lot of 29, 30-year-olds who are still very reluctant to have the jab. And I just, presumably you're trying it through the university, but I'm thinking of those who are outside the education system.
Okay, so what I'll do is I'll make sure that I include that in the report for next month, just as a summary position.
Thank you. Peter, would you like to ask your question?
Thank you, Chair. Yes, really to go back to something that was mentioned earlier about admission avoidance and the of GP in all this, because in the planning slide that John showed us, and I've got to say your overall report does look like very well advanced, joined up thinking. I've got to say that it looks like superb coordination, and no criticism on that. But GP input looked very, very lightweight, and to say the CCG is there, it would not be really an excuse, because as a GP said to me recently, the CCG, that's nothing to do with me. And I just wondered where GPs really figured in all this, because very pleased again to hear from Jane about admission avoidance. And I wondered where GPs were in actually at an operational level in trying to make sure people don't have to come into hospital.
Do you want me to take that, John?
Sure, and then I can add something, because I was presenting to GPs yesterday.
Okay, so as part of the UCR model, Peter, which is the service that we've got in place that sees us work with GPs and advanced nurse practitioners to support patients at risk of admission. So they're patients that traditionally end up being triaged and needing what we call a response within 0 to 2 hours. Within the PCNs, we work really closely with the GPs. So our intermediate care crisis response service alongside the local authority. We put services in there to stop patients going into hospital. But the anticipatory care work that Amanda talked about earlier will really, I think, push us to the position of being able to really work together with the GPs so that we stop the crisis in the first place that potentially leads to the admission. And
that's what I had in mind.
Where it's, yeah, and probably where we do it, an example where we do it really well is in the care home support service, where we take that really proactive approach. That needs to be now rolled out across into people's own homes that aren't in care homes.
Thank you. Is that fine, Peter?
Yeah, no, that's fine. I thought John was going to say something about. I thought John was going to add something.
I can certainly give you some feedback from the clinical strategy group, which I did a very similar presentation to this yesterday.
Yes.
And that was to like literally about 16, 20 members within our primary care. And they said it was really good. They could see that a lot of work had gone into it. But then they said, well, what can you do for us to help us with what we're facing? And my answer to them has always been, it's not a case of what I can do for them, but how can they support the system? We've got to approach this on a system basis. Yes. So, you know, with that work that James mentioned about the hospital avoidance, with some of the work that we're doing, we've reintroduced with our primary care colleagues things such as the operational level emergency levels, so the OPAL levels, so that they can have a voice to say, OK, well, we are struggling, but it's very hard when it's a case of we've got 67 practices, as you know, across Kirklees. We know some of them may be struggling, but it's not one voice. OK, we've got the single voices of the PCNs maybe, but it's very difficult. Whereas we can go to someone like CHFT, or I can go to my colleagues Amanda, Richard, etc., and they can give me an OPAL level, or they can summarise how they're struggling. But to try and do that across 67 individual practices is very difficult. So we are trying to improve all of that within our winter planning, as far as making sure that GPs have got a voice. But like I say, what I am trying to get over to them, it's a case of this is a system approach to the health and care system. So it's not a case of like, how can you help us? It's a case of how can you help the system and the system help you? So that's what we're trying to do at the moment.
Thank you. Thank you, Chair.
Thank you. Councillor Liz Maid, would you like to ask your question?
Yeah, thanks. Mine's on primary care, actually. Like Peter, concerned about the access to primary care during the winter as being one of the primary front doors into the health system. And it's good that extra appointments have been put in. That's, you know, extra appointment capacity has been put in. That's good. But are the CCG also able to help if there are areas where having difficulty coping with the number of telephone calls coming into a practice, because where you have people maybe struggling to get hold because of the sheer numbers that there might be during the winter, trying to get hold of their GP practice, if that isn't working, and then people are going to show up at the local A&E, etc. So how are the CCG supporting practices as a key part of the system in being able to have access to them? Thank you.
Thank you. Who would like to answer, Liz? Shall we take both the trusts? John.
If I can just mention, like, it's very difficult just on a basic operational level as far as the phone calls, for instance. What you've got there are 67 practices with 67 different phone call systems. So at peak COVID, we did redeploy some CCG personnel through mutual aid and through other partners into some practices that were really struggling, you know, because they had a lot of people off with COVID, etc., etc. So we've done all of that. Most recently, as far as CCG support into primary care regarding this idea of having this access into primary care through the telephone network, I had a practice earlier this week whereby of the 7 people that work in reception, one of them went off with COVID and the other 6 were COVID contacts, and they needed to leave in order to get a PCR test. That would have taken that whole reception team out for the whole of Monday and the whole of Tuesday in order to allow for that 24-hour PCR test result to come through. What we were able to do is, again, working in a system way, that was flagged up to me, and I was able to get them into the 2-hour response turnaround into the acute trust, which is the near patient contact testing, in order to get a 2-hour turnaround on that. So we do it. It may appear firefighting, but it's a system response. It's a case of, OK, this part of the system, as far as that specific practice had an issue, we were able to rely on another part of the system in order to get it done. Yes, it did mean that those additional 6 reception staff did need to go down to HRI in order to have that test, but at least they got the results within 2 hours and were able to actually come back into work and support that GP practice on the same day, as opposed to having 48 hours out waiting for those results to come through. So we are trying to be as responsive as possible, but it's a national issue as far as this whole access into GPs. And I would say when we've done work within the acute trust, when we've had people within our ED departments and actually spoken to people about, look, why are you here? And they're turning around and saying, I couldn't get an appointment, or I've tried ringing, and etc., etc. Or they've said, you know, I've rung my GP and they've said to go to A&E. We've done some work with our colleagues at LCD, who often triage a lot of our 111 calls for home visits and so on. And that wasn't necessarily the case. I wouldn't like to say that our residents are lying to us, but I think sometimes it's a perceived idea that they are unable to access primary care. The last thing that I would want is that people hold back and don't access primary care. I really want them to access primary care, and we want to make it as smooth as possible for them in order to do that.
Thank you. Liz, do you have a supplementary? You're smiling.
No, I don't. No, I don't think there's. I think that perception is one thing, yes, but I think that there's also cases where there, you know, if it gets really bad and we have a lot of staff down with flu or whatever in the winter period, then there's going to be even more pressure on those primary care services. And to actually, it would be good to actually have a, you know, rather than firefight, actually have a plan, you know, in place to how to support them. That was just my thoughts. Okay, thanks, Amanda.
Okay. We don't have any further questions on that item of winter pressures. So I recommend the panel considers the information shared with the panel, and I also recommend that partners continually review risks throughout the winter and bring back to the panel if any major issues occur. And I'd like to thank all the staff and partners who have attended this afternoon, giving your valuable time so that this panel can discuss this item. Thank you. That takes us on to the next item, which is the Kirklees Joint and Health and Wellbeing Strategy Refresh. And I believe we have Phil Longworth with us and Alex Chaplin. Who would like to go first to recommend that item?
Thanks, Councillor Zaman. Just to introduce myself to the panel, I think I've met most people, but not everybody before. My name's Phil Longworth. I work under Richard Parry in this, and one of the things I'm leading on at the moment is the development of the Joint Health and Wellbeing Strategy. And we've got a small team of people working on that, and Alex is one of those. And she's going to help and support the conversation. Just to sort of remind people a bit of the background around this. We've tried to summarise it in the paper, so I shall be very brief. Mm-hmm. The Joint Health and Wellbeing Strategy it's actually a statutory duty of the main partners across health and social care. We need to make sure we've got a joint health and wellbeing strategy, and that people have sort of regard to it when they're doing their specific service planning and organisational planning. We actually did a joint health and wellbeing strategy when the requirement first came in 2013, refreshed it a bit in 2014, and it ran until last year, and we agreed that we'd spend this year refreshing it. COVID has slightly got in the way of that. So we're aiming towards having an updated joint health and wellbeing strategy early in the new year. That timescale is also probably useful just in terms of the sort of time horizon for the new joint health and wellbeing strategy, because we're thinking 5 to 10 years. So we're trying to make sure the conversation reflects that sort of timescale of ambition and aspiration. So we need to recognise there are some short-term pressures, but it is about the longer-term view. And obviously the joint health and wellbeing strategy needs to be informed by our understanding of the needs and aspirations of local people. So it's a sort of companion piece to the joint strategic assessment that we keep updated on a regular basis. So it is partly about how are we locally going to respond to the needs of local people. Just thinking about what's happened since we produced the first joint health and wellbeing strategy. Lots of things have happened. Some of the key things that didn't particularly feature in the previous joint health and wellbeing strategy. There was a bit of emphasis on place-based working, working in localities and neighbourhoods, but nowhere near as much as we've got now, particularly with the advent of primary care networks and the council strengthening its sort of locality and neighbourhood working. There was no mention of what might be happening at a sort of supra Kirklees level, particularly, and now that the West Yorkshire integrated care systems becoming established, we anticipate in legislation, there's obviously an issue about what it is we need to do at a Kirklees level and how we can collaborate with people across West Yorkshire to make the changes we need to. There was no mention in the previous joint health and wellbeing strategy of climate change, because it was just becoming the issue it is now. There was a lot of emphasis on qualities, but certainly in the conversations that have happened over the last 12, 18 months, that's come much more to the fore. And somewhat unsurprisingly, there was no mention of COVID, because in 2013, we didn't know that was going to happen. So part of what we're trying to do is think about what's different now from the aspirations and ambitions and ways of working we described in the previous strategy. One of the things we did say in the previous strategy is we need to work very closely with the economic strategy and the work being done to implement that. And there's still a real commitment to doing that. What's moved on a little bit quite significantly, I think, is that we've now said that rather than it just being the health and wellbeing strategy and the economic strategy that should be the key thing, the key strategies that are helping inform what we do across Kirklees, there's a third element, which is the inclusion framework that Jill Greenfield and colleagues are working on. So all the time through the work we're doing, we're trying to understand the interplay between those three things: health and wellbeing, the economy, and inclusive communities. And then there are things that we need to thread through that, like how are we doing economic recovery in a sustainable way that's not contributing to climate change, and how are we responding through the health and wellbeing strategy to those challenges too. The other thing we're very conscious of, there's been a huge amount of work, and Helen summarised some of the work that Health Watch has been doing earlier in the meeting. Huge amount of work done about talking to local people about what their concerns, their aspirations, expectations are. So there's the work that Health Watch are doing. Colleagues might be aware of the work that's been done by other council officers around the place standard in lots of different communities, and going out directly engaging with lots of people about what it's like to live where they live and what they want to see change and improve. All of the work we're doing is trying to build on that and draw on that. So rather than going out to people and asking them a separate set of questions, we'll be trying to build all that engagement work into the revised joint health and wellbeing strategy. So there's a couple of things that we wanted to talk about. I've actually prepared a set of slides, but I'm very conscious of time, so I'm thinking that I might share those, but literally whiz through them at breakneck speed, just so we can point the conversation at a couple of questions. And the questions really are: have the panel got any reflections on the way we're hoping to engage people with the joint health and wellbeing strategy and thinking about how it needs to change and be updated. But most importantly, certainly from our perspective, is so what do we think our ambitions should be for the next 5 to 10 years in relation to health and wellbeing? So if these very quickly. So I'm hoping you're seeing. If somebody could shout to say that they're seeing some
Yes,
slides.
we are.
Yeah, we can see
excellent.
it, Phil. Thank you.
Excellent. I'm never sure what happens when I press those buttons. So that's a bit of the background. We're trying to structure the conversation around a number of questions to make sure that there's some sort of clarity about the thought process that we're going through to get us to the really important questions, which are those last two there, about what are our aspirations, what are our ambitions, both for our communities and collectively. Feels important just to encourage people to reflect on the current joint health and wellbeing strategy, because obviously we don't want to jettison key elements of that if people still think they're relevant and useful. So there's just a bit there to remind people of what we said in 2014. And so for some of us, I think we'll remember the work that we did back then and think we've made some progress, but probably not solved all of those problems. I've no intention of reading through all these. Mm-hmm. But I was quite reassured, and I know other people have, when they've looked back and reflected on this, thought, yes, actually, we have been working on most of those things. So obviously, based on what I said earlier, what our analysis of need that we articulate in the joint strategic assessment is telling us is important. But what we want to do is just test that out with people as well and say, are the key messages, which we've tried to summarise on some of these slides at a very high level, are these key messages still the right ones? What else do we know? What do we know now? How's it changed? Particularly, how has it changed during as a result of COVID? And part of what we want to do, and if people might have had a chance to look at the Rachel Spence-Henschel's Director of Public Health annual report this year, is try and use that life course model that Rachel used in her annual report as a way of helping people to talk about some of the issues, and the point that Councillor Warner made earlier about so what about those people in the 18 to 34 age group, because there are particular issues for them that are different obviously to people in the sort of 60 to 79, 80 plus, and using that framework as a way of understanding what's going on in people's lives. And like I say, getting people to share with us particular issues around their lived experience. Sometimes the data doesn't tell us everything we need to know about what's going on in people's lives. We've been trying to put a lot more emphasis on asset-based approaches, thinking about the positive things and how we can build on those and contribute to them, but not obviously glossing over the fact there are barriers and that people face. We have actually in the health and wellbeing plan, which we produced in 2018, articulated an updated set of ambitions, particularly from a health and social care system point of view. And again, it seems important to get people to look at that and say, do those still make sense? Do we need to update them, add to them? Are things less important now than they used to be? People will be aware that we've got a set of Kirklees outcomes, and there's been quite a bit of work done over the last few months around a citizen-focused outcome. So we've got 7+1 outcomes, and they feel like an important way of continuing to frame the conversation about, so what is it we need to do to enable us to achieve the outcomes that we've set for ourselves. There are a few things that have already emerged through the conversations that we've described here as big ideas. Quite a lot of them, the ones without a bold border, are ones that have been big ideas for a while, because they are an evolution of what was in the original joint health and wellbeing strategy. The ones that feel different, I think I've alluded to a couple already, increased focus on locality working, how we're dealing with the climate emergency. But the other thing that's changed, and is particularly significant in terms of the new West Yorkshire Integrated Care System arrangements and the legislation that's passed through Parliament at the moment, much more emphasis on providers, particularly providers of health and care services, working together in a much more integrated way, but that not being something that's a choice, but is something that's an expectation and a requirement through the whole of the health and care planning system and delivery system. And the final thing, just to highlight, is about telling our story. I think there's been a real sense that we've not been very good at explaining to people what's going on in Kirklees, what are the good things about what's going on in Kirklees, how we're responding to some of the challenges. So a real sense that we need to get better at articulating what we're trying to achieve and how we do it. So that's just a bit of detail about each of those. Yeah, so some questions, and it does feel useful to try and focus the conversation around those last two, because they feel like the questions that are really setting the agenda that then the different organisations across Kirklees and the partnerships we've got need to respond to. What are our ambitions for ourselves and our communities? And yeah, so what are our aspirations and what are our ambitions? So if I work out which button to press to stop sharing, that'll does that stop sharing?
Yeah. Thank you for that, Phil.
Yeah, so it'd be really useful to get any reflections on those, on the approach, but particularly those questions around aspirations and ambitions.
Okay, we have Peter, you have your hand up. Would you like to ask your question?
Peter, I think you might be on mute.
Sorry, apologies. Thanks for that, Phil. You know, I'm sure a lot has happened, and I'm sure COVID has got in the way. Just to comment, publicising yourselves, the university has just sunk some money into a new health and wellbeing academy, which you might think, you know, but it is a means to publicise what you're doing. Joanne Garside is somebody you might speak to about getting publications in.
I was supposed to have a meeting with her yesterday, but unfortunately we had to cancel due to conflicting diaries. And I'm also talking to the Dean of the School of Human Health Sciences, Paul Bissell, about how we can make sure that the university is contributing to the process around developing the joint health and wellbeing strategy more generally as well.
Yeah. Sorry, that was an aside. My question really was, Phil, that you know a lot of what you said has been summarised in the last few days, and writ large, and as you said, will appear in legislation. And I wondered what your perception was of levelling up, and how you think levelling up differs from trickle down, which we had under Mrs. Thatcher in the 1980s. Because clearly the Black Report came out in '79, and then the guiding principles for all you're doing says that the whole idea of health and well-being didn't improve one iota on the trickle down. How's levelling up going to alter it, please?
I feel like the professor's just set me an exam question there. One of the things that's I think interesting, if you look at the joint strategic assessment, there are across a whole set of indicators progress. So infant mortality was one of the things we highlighted on there, and people might remember when Judith Hooper was Director of Public Health, and it was around about the same time as the first joint health wellbeing strategy. We highlighted that as a major system-wide challenge, and we made fantastic progress. We went from being one of the worst places in the country to being about average, which was a real example of how we managed to bring people together, focus on an issue, because it wasn't something that could be solved by the hospital maternity services. It was about a whole range of factors and bringing attention to those and focusing on them. So we have got really good examples of where locally we've managed to make a real difference to what felt like really knotty and intractable problems. And I think that's part of what's come out already in the conversations about what the joint health and wellbeing strategy should be doing. Pick the big, what's a big challenge and how can we deal with it locally? That's not to say, though, that there aren't things that have got worse, because if you look at some of the other measures in that are in the joint strategic assessment, they are continuing to be challenging. Where we're at in terms of healthy weight is an example of that, and a nut we have definitely not cracked. So that's me slightly dodging the issue that you, or the question, Peter. I admit to that, but I think there are examples where we have said in the past, let's set our collective ambition, and we can achieve that. There will always be national.
I think
both help and hinder our progress in those things.
Yeah, I think your economist colleagues, probably have got something to say about this as well. And I don't think anybody knows the answers, but whether these things are aspirational or whether they're just pie in the sky wishful thinking remains to be seen. And I think probably the responsibility on you is to produce tangible, measurable numbers.
Can I just mention another aspect of it, though, just to build on your question? But when we highlighted inequalities as a key challenge in the first joint health and wellbeing strategy, it felt like something where we were almost swimming against the tide. If people look at some of the national policy announcements over the last few weeks that have manifested themselves in the guidance that's come out to the health and care system in particular, it's really clear that inequalities has gone from being something that public health people should concern themselves with to being something that everybody who works across health and care and the wider system is going to be held to account for. So that feels like a really positive and helpful development that should mean our ambition hopefully can be realised.
Thank you, Chair.
Thank you. Dave Rigby, would you like to ask your question?
Yes, thanks. Yeah, Phil, you mentioned what were our aspirations and ambitions, and in the covering report, page 80 of our pack, there is a reference under paragraph 3.4 to climate change and air quality, and you do mention that was a gap in the previous strategy. It's also an issue that as a scrutiny panel we're interested in, so it's good to see that in there as an area you'll be looking at in more detail. So that was the first point. The second point is really just to do with the engagement pack, the details in Appendix 1, and there's reference to the 3 documents. There's the Health and Wellbeing Strategy, there's the Joint Strategic Assessment Overview, and the Health and Wellbeing Plan. And I think as far as the engagement's concerned, it's important there's some clarity about what the consultation is over. Is it over all 3 documents, or is it focusing on particularly the strategy? And I did notice in terms of the way the questions were phrased in the engagement pack, that they could probably do with a bit of plain Englishing. And particularly, I think if you're looking at consulting or engaging quite widely in relation to the refresh.
That's really helpful. Thank you. If there are particular questions that you think are not plain English, feel free to stick it in an email. It would be useful to know, because sometimes when a few times you can't see what other people can see. So
I think the questions are couched in a language which is perhaps aimed at fellow professionals in the field. Certainly as far as I was concerned, I was thinking, well, I don't actually quite know what you're getting at here. But yes, if I've got any specific points, I'll let you know in an email.
Thank you. Thank you.
Thank you. Councillor Leslie Warner, do you want to ask your question?
Thank you. Yeah, I'm a real lay person, so I don't do language, and I'm not even very good at the word strategy. So I'll be honest and say, you know, when Peter said some of it feels a bit pie in the sky, I mean, given the world we are currently living in, with the values we've got, I would have, you know, many people have got, I suspect, an aspiration just to have a National Health Service in 10 years' time. You know, and if you're wanting, you talk about telling our story, I mean, I think there is a big issue there about not enough people feeling they have a voice. I mean, I'm always aware that, for example, Scrutiny, we rarely have public questions or deputations like you would elsewhere. But I think if you were to ask stories, the number one thing at the moment, as has been referred to earlier in the Scrutiny, is, you know, people just want to see their doctor. He was their friend and it's gone. And there is quite a lot of despair. I mean, for all the wonderful things and the hard work everyone is doing, which I appreciate. And, you know, the top of the list by far is the inequality, which just seems to be getting more extreme, not just in Kirklees, but across our country. And I think it's fantastic to have these strategies and ideals, but just personally, I'm just not quite sure how in the current climate, some of these are able to move on at all. I'm not trying to be depressing or negative. I'm just, as you were reading it, I'm thinking, yeah. But, you know, look at where we are at this moment. It feels quite, well, we'll use the word challenging, which is a word we hear a lot of at the moment. So, yeah, I'm just putting my penny within, not trying to be negative, but just a little bit confused as to how you can take things forward in the present climate.
Thank you, Leslie, for those comments. Phil, are you wanting to reply back to Leslie? You don't have to. I thought you were going to.
I am going to. I'm just trying to work out how to phrase it. I've been in quite a number of conversations where people have been reflecting on what's come out of the last 18 months, and that there have been a few things that feel really positive. So the fact that so many people came together to help their neighbours and the other vulnerable people, it feels incredibly positive. It was born out of the worst of circumstances, but it produced something very positive, and there's a real desire to try and sort of keep hold of that. And we're doing some work on a loneliness strategy and various other things to try and keep hold of that and cherish and nurture those things. Similarly, and I think some of the conversations earlier about how we've responded to winter, because it feels like we've been in 18 months plus of winter because of COVID, and lots of people who are involved in the health and care system have they've appreciated how they've been valued, but what people have really appreciated is the fact that everybody's had that sort of sense of common purpose and cutting through some of the historical sort of bureaucracy and, you know, sort of organisational interest to really come together and say, what's in the best interest of the people who live in Kirklees, particularly those who are most vulnerable. Let's all just put our shoulder to the wheel, crack on and do it. And I think part of this is going to be about how we capture that and keep it and nurture it and encourage it. There are clearly, you know, challenges to doing that and broader ones, but, you know, I'm a glass half full kind of guy. And I think part of what lots of people have said in the discussions we've had about the jaws so far is we need to stress that positivity and not completely dismiss and ignore some of the challenges, but approach the whole thing from a very positive, asset based in the sort of jargon point of view, and see how we can use those to try and make people's lives as good as they can be.
Thank you. Leslie, have you still got your hand up, or have you? Leslie, we can't hear you. You're on mute.
No, sorry, I was just going, no, it's fine. I mean, I think it's, you know, I try to be positive myself, but it's just sometimes it does feel a little overwhelming. And as a governor, you know, the word blood and stone sometimes come to my mind when you have to listen to what is being dealt with. But, you know, great.
Thank you. Can we move on to Lynn Keedy? Lynn, would you like to ask your question?
Thank you, Chair. I'll whip through my comments really quickly, if I can. I'm looking at the KJSA key messages page, and it just struck me really that perhaps we could add to that isolation and loneliness as a current cause of concern. Also to highlight that alcohol plays a significant role in dual diagnosis presentations and can ultimately contribute to loss of life. And I think it's important to mention that because we've got drug-related deaths, but we haven't got anything on there about alcohol, which may have become even more of a problem during the lockdowns of the pandemic. I appreciate why it mentions male suicides on the list. I know the background to all of that because I do attend the Kirklees Suicide and Self-Harm Prevention Action Group meetings. But actually, from my point of view, all suicides are a cause for concern. So I think that perhaps ought to be reworded. Very quickly about diabetes, what about sending in dietitian support to the food banks? Because inappropriate dietary habits can embed at an early age and just add to the problem. And it's about how do we have a healthy diet on a budget approach. Also, just very quickly, looking at page 98, the comments where it's talking about personalisation in the list of things. I think that is a key one because it's about basically involving people, asking the right questions of them, and then listening to the answers and responding, because person-centred care and support is a really important part of getting people on board and sustaining lifestyle changes and things like that. And just finally, very quickly, telling our story in terms of the team telling the story, but as was mentioned earlier by one of my panel colleagues, allowing people to tell you their stories as service users and carers. Lived experience stories are about the most powerful learning and training tool that you can have. So I really just wanted to put all that on the record and thank you for the opportunity to do that.
Can I just pick up on a couple of points that might help? I think on your agenda plan there's the click survey, but for the next meeting, I think. One of the reasons why we've sort of pushed the timeline for this back a bit is we're undertaking the click survey in a few weeks, and we want to be able to use the results from that, which will help us understand a bit more about how those issues, particularly ones around loneliness and isolation, and also people's behaviours like alcohol use or misuse. So we should get a bit more insight into what's changed for people over the past sort of couple of years on that. And the other thing is just on that the stories and people's lived experience. At the Health and Wellbeing Board last week, we had a presentation from the Kirklees Better Outcomes Partnership, and we're trying to really showcase those examples where we're taking a much more personalised approach. And I would encourage people. I'll share the link. I would encourage people to have a quick look at that presentation because it's inspiring stuff about how if we take a different approach, given the limitations in terms of resources, etc., we can make radically different interventions in people's lives, and they're ones that will make them that do have a much better impact than the the traditional approaches we might have used in the past.
Thank you. Councillor Liz Smage, would you like to ask your question?
Yeah, thank you. Phil, I've been also around quite a while. I think it is a step forward that so many people now are talking about health inequalities. I really do. There have been conversations for a long, long time on health inequalities, and I think it's good that health across health, there is now more awareness of health inequalities and the impact that has on the services, etc. And that people need to not just look at health, but also how to help with those health inequalities. And the link between well-being and health. Because if somebody's well-being, as has been said, if somebody's well-being is not right, then that impacts on somebody's health. And we've often put in, when we've had reconfigurations and things like this, we've often said that the whole system needs to take account of the health inequalities as part of that work. And so it is a step forward that's now at least being discussed. But I would like to ask, when you're doing this refresh, there are different health inequalities across Kirklees that will have got a lot wider over the past 18 months. And it's how those are shown in your strategy. So there are health inequalities that are prevalent across Kirklees, and there are health inequalities that are more localised health inequalities. And therefore, it's how you're going to separate those out so that people are focused on what is needed in an area, not just as a whole. Thank you.
Thank you.
Can I add to that as well? Because there's also been quite a bit of new work and understanding and thinking about particular population groups. People with learning disabilities is a really good example, because the most important thing for them is not where they live, it's the fact they've got a learning disability and they experience significant health inequalities. So part of what we're trying to encourage people to do is think about it in quite a sophisticated way. And the risk of getting into jargon, the population health management approach that we want to take is encouraging people to think about those things in those different ways.
I thought Liz was going to say something again.
Oh, sorry, no, I was just going to say thank you.
Thank you. Thank you for those very pertinent points, Liz. Okay, so now what I'd like to do is ask the panel to note the views expressed by the panel members on the proposed approach to the strategy and the high-level aspirations and ambitions in Kirklees for the health and well-being of its residents. And thank you, Phil, for attending.
Thank you.
That takes us on to the next item, which is the work programme. And if I could ask Richard to take us through that, and also the vaccination information.
Yeah, that's fine. Thank you, Habiban. Right, I thought probably the easiest thing to do would be to focus, if we can, on the agenda plan, which is on page 107 of the pack, because I just thought it'd be helpful just to sort of focus on the items we've got coming up in the next couple of meetings, and obviously to seek panel members' views in terms of what other items I may want to get scheduled in either for this year, or we maybe need to start looking for the early part of next year as well. So if I can just start first and foremost with the November meeting. We've currently got two substantive items on there. The first one is the community care services update. Just so we're clear on that one is that's going to be predominantly going to be fronted by Locala, although we will have CCG colleagues, and indeed we'll have colleagues from adult social care attending as well. The idea for that particular item, and it is obviously covered as part of in our work programme, is that it was basically to look at a broad overarching, because it's part of a broad overarching theme that covers the integration services across the health and adult social care sector. And so what we're asking Locala specifically to do is to come to the panel to look at the progress and effectiveness of the community care services that are delivered by them. And we've asked them to include examples of the coordinated approach to providing care and support in Kirklees, and how this integrated way of working has actually helped reduce unnecessary A&E and hospital admissions and delays in discharge. We touched a little bit on some of that today's discussion, but we'll obviously go into a lot more detail with them at that meeting. We've also asked for an update on the progress of work that's been considered to develop a same-day urgent or an emergency response model in the community, and that's the work that's been done in conjunction with the primary care networks. And also we're asking them for an update, and I think Lynn, you mentioned this at the last meeting, was on the proposals to merge the Gateway to Care service and the Locala single point of contact service. So there's a lot to cover in that specific item. And then in addition, we've also got the Kirklees Care Homes Programme Board update. And on that one, they will be coming back. They've been before, if you remember, to provide an update on the progress of the board, which will cover looking at the key issues and challenges that they've identified in the actions they've taken to address them. And it will also look at the training support that will be provided to care homes, and look at the areas around end-of-life care plans, testing and swab taking. So again, there's quite a lot to cover there, and we should also hopefully have the outcomes of the analysis for the home care market and the implementation plan. And we should also get a copy of the final report from the consultants who did that work. So that's November. Now, I think personally there's a lot to cover there. So I just wanted, first of all, before we move on, whether panel members have any comments there, whether they think that should be sufficient enough to cover, or are there any areas that you think we've missed in relation to those particular items?
There seems a lot to go at, Richard, really.
Yeah, it will be. I am expecting it to be obviously a detailed discussion, and obviously, as you say, we will be covering a lot of ground there, particularly in relation to the community services work. I think Leslie, have you got your hand up? I think you're on mute, Leslie.
Sorry, can I just check that also by then we're sort of really heading into winter, whether we can just get, I know we're not going to have a full COVID report, but whether we can at least have, you know, a brief summary of what the latest figures are and any concerns that need highlighting.
Yeah, I think as part of the approach that we said we'd take to the COVID is that we would continue to have lines of communication open between obviously the panel and public health. So yeah, I'm happy to feed that back to public health. I mean, the figures are already available. I mean, they are regularly updated on the website. Yeah. So we're able to keep a handle in relation to the rates, but I can certainly ask public health if there are any particular emerging issues or any areas of concern, which we can then get reported back to the panel. So yes, that's something we can cover. Yeah.
Thank you.
Peter.
Yeah, only just to add, Richard, that the trusts last year did seem to give fairly regular reports about how they were doing as well.
Yes, We can potentially look to do that again, Peter. That was I think it was done every month, wasn't it? In terms of the sort of like a general update, wasn't it, from both the acute trust?
Yeah, something like that. A monthly seems to ring a bell.
Yeah, just so you're aware, just in terms of there are some changes that have taken place, certainly in Mid Yorks, because Martin Barclay, you may or may not be aware, has now stepped down as Chief Executive of Mid Yorkshire Hospital Trust. There's a new Chief Exec, Len Richards, I think his name is, who's come into place. And Habiban's got a briefing, haven't you, Habiban, with
I have.
him? It might be next week or the week after, certainly in the next couple of weeks. So as part of that discussions, Peter, we can touch upon obviously the issues around winter pressures, and I'm sure he'll be supportive of providing some updates for the panel during the winter months. Yeah, so we can look at that again.
Thank you.
Okay. Right. So in terms of November, then I think broadly speaking, I get an impression that we're agreed that should be sufficient items in terms for that meeting. In December, we've as requested by the panel, I have contacted CQC and I have invited them to the meeting. I'm pleased to say that they've confirmed that they are happy to attend. They will, if you remember in previous years, usually give us an update across the board in relation to the overall state of care in Kirklees. And they'll look to do a similar obviously update again. What I have said to them is that obviously that there has been a request to have a specific focus, I think, on adult social care, because it has been some time since we last had an update on that sector. So I have made that clear that the panel would have a specific interest on the adult social care directorate. But having said that, we will have representation from directorates that cover the primary medical services, mental health, and the acute hospitals as well. We've also asked them to pay particular attention to the impact that the pandemic has had on the quality of care, and their views on this obviously as well. So it should be quite, I'm hoping, an interesting discussion. In the past, when we've had CQC, the discussions have been quite detailed, and we've spent quite some time with them when we're looking at this issue. So at the moment, that is the substantive item. It's whether members feel that will be enough, and they're happy just to have a meeting that focuses purely on the state of play with CQC. We can invite, and we have in the past invited partners to the meeting. I haven't done that yet, but if you think that will be helpful to have representatives from those areas also attend, then that's something we could do as well. So we would have a much broader discussion around the state of play in Kirklees. So it's, I'm probably would seek your views in terms of that, please. Peter?
Yeah, I mean, I wouldn't want to see it restricted or narrowed, Richard, but I think that they're probably likely to be far more open if, and tell us what they think. If the bodies to whom they assess are not there, but that's not to say we shouldn't have that and then have the bodies to whom they assess afterwards.
I understand that. We have in previous years had a meeting where we've had part of it done in a formal setting and part of it done in an informal setting. I don't know if that's what you were.
That's what I had in mind. I think in the private bit, the non-public bit, we kind of got to very good understandings with them, and I thought they were very frank. I seem to remember last time they didn't bring their representative for adult social care, so we were a bit stumped on that. The team's a bit lightweight. The chairman did very, very well to fill in, and you know, they got somebody there on dentistry, which was great. Not an adult social care, but that's what's in mind, Richard. Part private and part.
I think. I think, as I mentioned, I have asked them for a specific focus on adult social care, because I know it has been some time since we had a specific discussion on that sector. So they will be in attendance. I think we just need to give some thought, Peter, in terms of how we approach the format for the meeting, because obviously what we want to make sure is that we have an open, transparent and public debate about obviously the state of care in Kirklees. But I do appreciate your points. Occasionally, we do touch upon areas which are quite sensitive, particularly if we're talking about named organisations, for example. So that is something that we will obviously need to consider. But obviously, I'll take on board your point. Lynn?
Thank you, Richard. Yes, just to say that I concur with what Peter was saying, and so I won't repeat it all. But yeah, thank you.
That's great, thank you. So in terms of items for December, is there anything on the actual work programme itself that you feel should go into the December meeting, or do we now, or can we now start looking further ahead? I think Leslie.
Mental health and well-being. The money that we were all had as ward councillors for mental health was last year, and we have a new focus now. But we are aware that many young people who were having support, and there's still many others who didn't get supported. And I mean, whether we do it in December or January, but I'd like to think that the mental health is something that should come to the fore, if that's possible.
Yeah, no, that's absolutely right. I mean, we have again, that as an overarching theme, we have mental health and well-being on the work programme, don't we? And there is a lot to cover there, actually, isn't there? If you start looking through some of the areas that we have included as part of the areas of focus for the panel, and I agree. I think it is a very, very important part of the work of this panel. So I think I'm quite happy to look at that. We can look to schedule something in. And I think we can organise something either towards the back end of this year or indeed the early part of next. But you're right, we'll mark that down as something to consider. Thank you for that, Leslie. Peter?
Yeah, sorry, just to say, Richard, as we go into the new year, I would assume it's probably logical to go with the items we've got, and just to bear in mind that we might get shot off course if flu and these other things and pandemic COVID, if we get another onslaught of that, another new variant.
Yeah, I think that part of the approach, as I said, we've got with public health is that they will hopefully alert us if there are any emerging issues, such as, for example, a new variant coming through. So we will have to be flexible in that respect. And I think as Councillor Zaman mentioned when we had the discussion around winter pressures, that we have asked adult social care and health colleagues to come back to us if they start to experience any significant issues or any major concerns. So you're absolutely right. I think with our work programme, we always have to accept there are going to be things that we don't know about yet. It suddenly come left field, and we will have to obviously take that into account. So I do appreciate that. Dave?
Yeah, just a couple of items. The first one's the very first one on our list, the financial position of the health and adult social care economy.
Yes.
Which I don't think we've covered so far. So maybe we could add that in. Well, possibly December might be a bit busy for that, but maybe February. And the other one is we have mentioned the health issues in relation to air pollution, and I've got a feeling that and health issues arising from climate change are kind of rising up the agenda generally. So maybe we could look at that for later on, maybe March or April.
Yeah, I think in terms of the financial position, I don't know if you remember, but when we talked about that at the beginning of the year, we were advised that probably that will be better to cover towards the back end of our municipal year. So it hasn't been forgotten about, and it will be scheduled in. But we were told that probably it'd be better to wait until then. In terms of the air pollution stuff, I actually had down that was a possible joint piece of work with our colleagues in the economy and neighbourhoods panel. So so I do need to speak to colleagues on that panel to see if there's any areas they're picking up on air pollution, because I think what I wouldn't want to do is duplicate the work. I mean, our focus very much on the health aspect, economy and neighbourhoods. Obviously, health is a key issue, but also there'll be other elements in terms of what measures have been taken to try and mitigate air pollution, particularly around traffic and volumes and stuff like that. So yeah, I think I agree with you that it is something that is obviously going to be on high on the agenda. Right. So, is there anything else? Because there was just one other thing. Another matter that has come to light. I just wanted to sort of brief the panel on. So, is there any other specific comments around the work programme before I just highlight something else that was brought to attention around the vaccination programme?
No, I'm okay with that.
Okay. All right. Okay. Right. So, I think. Lynn, you're on the line. So, Lynn, I think it might be helpful if you just provide members with a brief overview of the concerns that you had from someone who attended the vaccination centre at Cathedral House for their booster jab.
Thank you, Richard. Yes, I'll try to just summarise really. Someone who knows that I sit on this panel just brought to my attention an experience that they'd had on Wednesday of last week whilst accompanying an older relative for the third COVID vaccination down at Cathedral House. And the experience was such that I felt it needed to be raised, but not in a formal confrontational way, but more in an informal way. You know, this is early days. You know, what can we do to make sure that this doesn't keep happening? And it involved problems with the car park being full. So having to go to an overflow car park that was actually across a busy road that then had to be crossed in two directions going to and from the premises. And then quite a lengthy loop of a queue outside the building, which took half an hour to progress through to actually gain access to the building itself. Then the large room that was previously used earlier in the year on the ground floor for the vaccination programme was actually taken up for another purpose. And so it was necessary to go upstairs. And yes, there was a lift as well as several flights of stairs, but some people were quite reluctant to use the lift without support. And it was a day when there didn't seem to be a great many volunteers around. And then having got upstairs, there was another standing wait of quite a substantial length of time before the actual vaccination was given. And these were people in the older age groups of 80 and 90 years plus, and some people who are deemed clinically extremely vulnerable, who are of a younger age but still have serious health conditions. People were really struggling with remaining standing all that time. There were very few seats around, and also toilet facilities were needed. People had in some instances come alone and by taxi. They'd booked taxis to go home again, but the taxis were going to be coming too soon because they wouldn't have had their jabs. And I think they'd based the booking time for the journey home on the past experience earlier in the year when they went before for earlier vaccinations. And so people didn't always have a mobile phone to ring the taxi company to change the time, etc. And overall, it took 1 hour and 40 minutes from arrival at the back of the queue within the complex to actually leaving, having had the vaccination. And it had caused a great deal of anxiety and distress for a lot of the people who were surrounding the person that gave me the feedback in the queue, particularly people who'd attended unaccompanied. So that's it, I think, Richard. Thank you.
That's fine. Thank you for that, Lynn. And so just to provide some assurance to the panel, on the back of the issues that Lynn has just described to you, I did write to the CCGs, and they did take the matter very seriously. They actually arranged for a assurance site visit, which they undertook on Wednesday. And we have now received back the feedback from that assurance visit, and I have to say there are a number of actions that they've identified which will be acted upon. So, for example, they are going to be looking to request more chairs at busy times, providing obviously there is no major sort of, for example, fire safety reasons. They will be looking to brief they have the staff outside, streetwise staff, whose roles are basically helping to direct people in terms of parking, etc. So they will be obviously briefed in relation to their roles and responsibilities. There will be an update and reminders on social distancing requirements. They will be looking at best practice in terms of the vaccination preps that they're looking to do, and they will be looking at the resources in terms of making sure that there is sufficient number of vaccinators present. And so basically they've covered most of the key issues that were highlighted, and so I feel quite assured that they've not only just addressed the issues, but they're actually taking measures to strengthen their processes. So I just thought it was helpful for the panel to be made aware that obviously when we are made aware of these kind of problems and concerns, we obviously do take it seriously. We work with health colleagues or social care colleagues, and they clearly do take it seriously. So I think at the end of it all, I think we've got a very positive result in terms of the outcomes of those concerns that Lynn mentioned. So we just thought it was helpful for you, obviously, to provide you with that feedback.
And we did get a response very quickly as well.
We did a very quick response, which again is very reassuring. So I think, Habib Bam, from my perspective, unless there's anything more from members, I think we've covered that item now.
Thank you, Richard. Well, that brings us to the end of the meeting today, and I'd like to thank you all for attending and the staff who have ensured the smooth running of the meeting this afternoon. And hopefully see you at the next meeting on the 11th of November. Bye-bye.
Okay, thank you very much.
Thank you.
Bye.
Cheers. Bye.
Bye.